Okay, I think we will get started now anyways. So I will present the paper, and I have to disclose I'm also one of the co-authors and was involved in the design of the study. Once Andrew joins, then he can take over. So let me share a screen here. I hope everybody can see my screen. So this paper was very recently published in JACC, so Journal of American College of Cardiology. It's called Stress Perfusion Cardiac MR versus SPECT Imaging for Detection of Coronary Artery Disease. So this is a fairly straightforward title that almost explains everything the study was about. The background of the study is also fairly straightforward. Perfusion imaging, CMR first pass perfusion imaging, has been around now for 20, 30 years. And it made its way only very slowly into clinical application, mostly because there were issues with reimbursement and with the political conflicts sometimes between cardiologists and radiologists. Overall, there have been previous papers in Europe, multi-center studies like MR Impact, and then single-center studies comparing MR perfusion imaging with other techniques, mainly nuclear. And there was a constant message that it is at least as good, if not better, in terms of accuracy than nuclear cardiology approaches. Now, 2-3 years ago, there was this huge effort. Actually, it started already 4 or 5 years ago. This effort to also get FDA approval for this approach. And that's why in a concerted action with Siemens and with Bayer, funds were acquired for a multi-center trial, and then it was decided to even do 2 trials, and they were called gadolinium for coronary artery disease, also GADA-CAD. There was GADA-CAD 1 and 2, which just were numbers to make sure that people understand that one trial is more in Europe, one in America, because of some details that are not important here. So the purpose of these trials was to provide the evidence that this technique can be applied with FDA certification. So the papers on the accuracy have been published before, so there is nothing new. So this paper had a specific task looking at, and this was a secondary objective, to see whether it was non-inferior to SPECT for detecting significant coronary artery disease, or for excluding the same, for that matter. So for this, patients were sought who had a clinical indication for a coronary angiogram, and then they underwent stress perfusion CMR that could be either a clinical or a research scan, and then with compared with a gated SPECT, so state-of-the-art SPECT technique. The SPECT and the MR images were analyzed by core labs, and the standard of reference was, and we had some discussion at that time about that, was a 70% stenosis. So not 50% as used in some other older papers, but 70%, because we know that in terms of flow dynamics, anything below 70% does not necessarily have a significant impact on coronary blood flow. So when we also allowed to have a CT being used to rule out coronary artery disease. So, and the analysis was per patient. So here you see the protocols. So the image acquisition, there were Siemens scanners because the study was partially funded by Siemens. And they had a certain acquisition protocol that was put into the scanners so that there was a standardized protocol being applied. It started with a cine, a short axis, and then a test, a short real-time cine to look at the quality of a perfusion scan. Then during adenosine infusion or after regadenoson injection, there was a real-time cine performed. This was the stress perfusion part. After injection of 0.05 millimoles per kilogram, that what you would typically call a half dose of gadolinium. So this is fairly standard now. And then a cine long axis, then the rest perfusion. And just as an aside, rest perfusion, some other papers and one very recent one have shown that you don't actually really need the rest perfusion in terms of other diagnostic accuracy. But anyhow, it was performed here. And then gadolinium was, after the second gadolinium injection for the rest perfusion, late gadolinium enhancement imaging was performed. As mentioned before, an invasive coronary angiography is served as a standard of reference, typically within 6 weeks of the CMR. And there was a core lab analysis also of the angiography using quantitative coronary angiography. So not FFR or something, but a visual quantitative analysis. Or on excluding coronary artery disease, a normal coronary CT could serve as that. The CMR core lab, there were actually several core lab readers, was blinded, 3 readers, and the analysis was performed by each of them. They were actually compared, but they were not hugely different. And there were 2 interpretations. One was stress and rest perfusion plus late enhancement. And one was just rest and stress cine MR. So that was also performed, but it's not that really interesting now. So then SPECT was performed according to the guidelines per the Association of American Society of Nuclear Cardiology from 2010. Within 4 weeks, standard protocol for the acquisition, and then also the core lab was performed. The core lab activities were performed by experienced readers. They had full access to stress and rest images, and also the polar maps. And 2 of 3 readers were required to agree on that. So standard statistical analysis for non-inferiority was performed. So then coming to the results, so here you see the age was pretty typical for patients with suspected coronary artery disease, around 55, 60 years old. The ethnicity was unfortunately mostly white. So you see 67%. But that's also the kind of the patient clientele that we acquire. Most of the scans were done in the United States, with a few in some other countries in Asia and in Canada. There's nothing really that remarkable about that. Maybe one should mention that prior coronary artery disease was known in terms of 16% of them having a previous MI, a known MI, or a history of PCI with or without stenting, no bypass patients. So most of the scans were done at 1.5 Tesla, the clinical standard. About 1/3 or a bit less than 1/3 was done using a 3 Tesla machine. A bit more than half, but roughly the same, had adenosine, a little bit less than half had regadenoson. So all relatively standard. So when for the inclusion, we encountered a couple of exclusions due to several reasons. One was the invasive coronary angiography or the CTA was not suited to serve as a reference evaluation. Then in 77% or 34 people, images were missing or did not have acceptable quality for the CMR. And about 20% had actually, interestingly, missing or low quality images in SPECT. And then the others were not really, the other exclusion reasons were not really worth mentioning. So here's a sample of patients or patient studies. So here you see the stress perfusion and the late gadolinium here. This is a nice example where you can see that there is an extensive perfusion deficit here in the LAD territory, which is not matched by the late gadolinium enhancement, where the infarct or more in the other regions. Here the associated SPECT and then the CTA and the invasive coronary angiography. So this is all relatively standard. Now this is the key figure, basically defined with a gold standard or standard of truth being at least 70% coronary artery stenosis by QCA. The overall accuracy, so as defined by the area under the curve, was 88 or 0.88 for CMR and 0.74 for SPECT. So even the standard deviations hardly touch each other. So there was a clear advantage of CMR. The overall, let's say, the points of discussions are then, this is a confirmation of previous studies, and one additional study should be mentioned here. This was the MR Informed trial, published a few years ago in the New England Journal, showing that MR, regardless of the accuracy, also has a strong impact on outcomes. It's in fact as good as FFR in helping manage clinical decision making. So, but when you're interested in accuracy, which is to me also only the second most important feature, so the impact of outcome is the most important. But if now here we're looking at the second most important, which is accuracy. So then we have to say that this trial, it was prospective, it was randomized, it was using standard methods and blinded analysis. So could clearly demonstrate non-inferiority. In fact, it also showed superiority of CMR over SPECT. The only point where it came close was the sensitivity, which was non-inferior but also non-superior to SPECT. So this confirms previous trials that the overall diagnostic accuracy of CMR is higher. And then keeping in mind that typically costs are also lower for CMR, the risk associated with the study, because it doesn't deal with radioactivity for patients and for healthcare professionals, is also lower. So this is a very strong argument for some may call it a nail in the coffin of nuclear, but of course there are other factors that keep nuclear currently still going. Although my honest opinion is that it should have gone nuclear cardiology for that application years ago, but it just took some time. So before I give Sue, who raised his hand, the word for a question, I will just finish up. The previous studies are in line with them, and here's an overview of the detailed numbers. You can look that up. So here's the central illustration, and looking at the comparison with others in a kind of this tree design. So you can see that the area under the curve, accuracy overall, specificity, positive predictive value, negative predictive value. So CMR was always superior except for the sensitivity, where it was non-inferior. Okay, so overall, I think this was an important study, and I wanted to congratulate Andrew because he has really worked hard on this. You can imagine these papers go through a long and very complicated and sometimes annoying review process. So that's what I had, and maybe before I briefly comment on the editorial, I give Sue the word. Sue, you raised your hand for a question, I assume?
Yeah. Thank you very much for this excellent journal club today. I was just curious about the specificity. So if the specificity is average, shouldn't it? I mean, if you said the specificity is average, shouldn't it be low for the standard deviation to be high? Are they not indirectly correlated? And my second question, Doctor, is if you may, with regards to quality assurance, are there any projects being done on the level of clinical research to do the quality assurance of perfusion and imaging studies? Thank you.
Yeah, so I don't know, I may have explained that incorrectly. So I don't know, the specificity was actually not the problem. So the specificity was 89%, which is actually for a test pretty good for a diagnostic test. Typically tests are accepted if the specificity is 0.7 or 0.75. So with 89, this is really good. The sensitivity was lower for both, for CMR and SPECT. But then if you're the other, what you may refer to is the positive and negative predictive value. And here the positive predictive value for stress CMR was 68%, which means that if CMR said, okay, this is significant coronary artery disease, in 1 out of 3, it was actually not. But that was even worse for SPECT, where it was in 1 out of 2 not, which is just may reflect that in the positive predictive value that readers were just eager not to miss coronary artery disease. So there's the core lab readers, they were just in a mindset, oh, let's not miss something, and they quote unquote overcalled a little bit. So which then of course dries up the negative predictive value. So overall, if there is a limitation, is we tend to, with both techniques, with SPECT even more, we tend to, in these studies, to slightly overcall. Now, this is different between centers. You have centers who systematically tend to undercall and others who systematically tend to overcall. This is just how sensitive people are. What it also says, of course, is that these analyses are, at the end of the day, still relatively subjective. So if you have an experienced reader or a non-experienced reader, this makes a difference. And if you have a reader who is more on the cautious side, not to miss something, or a reader who's basically saying, oh, okay, that's probably not coronary artery disease. And if you have clinical information that pushes you in one or the other direction, that may also affect the result. So this is definitely a persisting limitation of first-pass perfusion CMR, that it has this subjective component. Now, I will share also now. This was the other paper that I asked Andrew to talk about. This relates then to the fact: should we quantify perfusion so that we get rid of this subjective component? And this refers to your second question regarding quality assurance. So quality assurance, they are, of course, that was part of the FDA application, was our extensive submission material that had to be provided on the standardization of the process, quality management, and all that. Now, whether this is done in all the centers that perform first-pass perfusion MRI, I don't necessarily know. So, but it, of course, it raises the point that, hey, let's do that, and let's automate that, let's quantify that so that we do not need an experienced reader. And this is what Andrew did in his editorial, also published this year. Actually, it was just a few weeks ago or so. So where he makes the following points. So first of all, quantitative stress perfusion, I mean, has been validated, maybe not as extensively as some other techniques, but it has been validated, and there are actually several papers that will be, or data that will be presented at the next CMR. And there are a few papers are currently in the making. We have a consortium, so-called Aqua Consortium, where we validated this. So we have validation data for quantitative stress perfusion, MR. Then it's also pretty clear that the extent of perfusion deficits can be more easily defined and determined looking at quantitative perfusion maps instead of just looking at looking visually and trying to qualitatively quantify that. So then it also has been shown, although the data are still a bit scarce, that quantitative perfusion imaging also has a prognostic value. Then there are also ways to look at it that it may reduce the impact of artifacts, especially darkroom artifacts. On quantitative imaging, it's easier to not fall into that trap. And then, of course, another point that he raises here, that the quantitative perfusion imaging allows for less experienced readers to also get to a similar level as expert readers. So these are all arguments that support the use of quantitative MR imaging. But then he says that the societal recommendations, they, however, say that for patients with obstructive who have stable pain symptoms and undergo imaging, they promote the use of myocardial blood flow reserve as a useful tool. And stress MR with blood flow reserve measurement is reasonable. So they do not even bring up the point of quantitative perfusion imaging. So it's not in the guidelines yet. And one reason for that is that you need certain software. And if you have only just one or two companies that provide software for that, then you're very dependent on how well this software works. And then the software companies, they will not go forward necessarily with that strongly if it's not officially accepted. So it kind of, the cat bites its own tail here. So this is one aspect. And then the various methodologies to quantify the signal intensity varies between software. So this is also, there's some need for standardization. And so we need to just learn a little bit more about that, about the quality and the standardization and the robustness of quantitative perfusion scanning. So so he ends up with the phrase that there are many reasons to see a growing importance of quantitative stress perfusion MRI, even if the prognostic value may appear statistically similar to a qualitative interpretation. My take on that is that it definitely will come. It will be definitely possible to perform quantitative perfusion imaging semi-automatically or automatically with an additional review of a human, but probably also in future increasingly supported by machine learning. So I think quantitative perfusion imaging, CMR perfusion imaging, is definitely will come and will stay. Now, regarding the main paper that we published today, I think it was probably one of the last one that were necessary to really convincingly demonstrate that cardiac MR first pass perfusion imaging is better than the currently used standard, at least in North America, which is SPECT. So in Europe, for example, nuclear plays a much smaller role. Their CMR first pass perfusion imaging has a much stronger role already. And now that it's FDA certified since I think already 2.5 years or so, it is also will be more increasingly applied in clinical routine settings. So that was my take on the papers, and I apologize on behalf of Andrew. I know that he was traveling, and we had trouble with the delay. With the date, the usual date, and then tomorrow is the JCMR Journal Club, so we didn't want to compete with that, so we went away from Wednesday. So given all that, I'm grateful for you joining today on this basically extraordinary date. So if you have any questions, then please post them in the chat. So there is one from Fahime Ganbari saying, could you please briefly comment on the diagnostic accuracy of 3-vessel disease based on CMR compared to 3 SPECT? Was there a subset analysis? Yes, there was a subset analysis. I just don't think it is in that paper, but I think it is in the supplementary material. I would have to look that up. It was, however, also at the same, it was also superior overall, so it was the same overall result. So then from Rebecca, it was mentioned that attenuation correction was not mandated for SPECT. Do you happen to know approximately what fraction of studies were that? Do you have a sense of whether or not that disadvantaged SPECT at all in this comparison? Yeah, that's a very good question. So in fact, during the review and revision process, that was a point that was brought up by presumably a nuclear cardiologist. So while it was not mandated, it was performed, and I may be wrong here, but I remember that it was performing close to 80% of patients. So it was, the standard was that attenuation correction was applied. So this should not have disadvantaged nuclear. And then also from Rebecca, there was a composite assessment of the stress perfusion plus LGE rather than just the stress perfusion alone. Yes, that was, so both analyses were performed, and although I don't think it was specifically mentioned in the paper, but also the LGE alone, sorry, without LGE, was hold on, was here. But I'm aware that we analyzed definitely the scan even without the LGE, and it was still on average superior, but I have to basically bail out on that one. I cannot be 100% sure here. I will look that up and post that then. Okay. Unless there are other questions, we're already at the bottom of the hour. If not, then just unmute yourself and shout in between. Otherwise, we will post. Nicole is not here today, so Nicole will present the next CMR Journal Club in January. Then I already want to announce end of January is the CMR 2024. Hope to see lots of you there in London. And then the last thing that remains for me is wishing you all the best for this holiday season. Stay healthy and safe, and thanks for coming, and already all the best for the next year. And see you next time. Bye-bye.